So before I start with the panel, maybe I would like to introduce all the speakers. And again, no, I don't want to take much time. Maybe I can ask all the elegant speakers to introduce themselves by giving like 2 or 3 words about themselves. So let me start with Anthony, sir. Anthony, sir, are you there?
Yeah, I'm here.
Sir, I know you are the professor of ENT. I know everything about it, but then for the sake of the panel, can you just introduce yourself in 3 words?
Yeah, I am a professor in Madras Medical College. We've been doing endoscopic sinus surgeries from 2001 time. So, when we have started, before that 2 years, I was in forensic medicine. I was doing cadaver dissections because when I did my post-graduation, there were no endoscopes in MMC. So 2 years, I taught myself doing cadavers and then started doing this. And one of my interests is skull-base surgery, while the other interest is in endoscopic ear surgery that all of us know. That's it.
So thank you, Anthony, sir. And of course, I should tell that he is my teacher. He taught me all the basics and of course, even advanced surgeries. He taught me a lot of things in my PG course. So let us now go to Ramandeep, sir. Ramandeep, sir, can you introduce yourself?
Good evening, everyone. I am Ramandeep Virk. I am a professor at the PGI MER, Chandigarh. And my main focus of work is interior skull base, endoscopic endonasal interior skull base surgery. And that's, where my love for the surgery lies.
I should say, Ramandeep sir has many great students like, the students in SGPG, they always say that we learned everything from Ramandeep sir. I met those surgeons that SGPG guys, they're too good. And they always say everything is from Ramandeep sir. So he's a great surgeon, a great teacher. So maybe Pawan Singhal, Dr. Pawan Singhal, can you introduce yourself?
Yeah, hi everyone. I'm Dr. Pawan Singhal. I'm senior professor and unit head with Department of ENT and Head Neck Surgery at SMS Medical College, Jaipur. My areas of interest are anterolateral skull base, head neck, and cochlear implants. So I know Vinod is going to do a good job. Let's hope for the best.
So thank you, Pawanji. Pawan is like a jack of all arts. He does everything in ENT. Laryngectomy, ear, cochlea, that everything is he's a jack of all arts in ENT. So thank you, Dr. Pawanji, and maybe let us go to Tushar, sir. Sir, are you there?
Yes.
I know you're having a cadaver dissection going on in
Yes,
your
yes.
hospital. Yeah.
Yes. I'm Dr. Tushar Ghosh from Kolkata. I'm the director and founder director of the Ghosh ENT Foundation. It's a dedicated ENT hospital, 23 bed, 4 OT, and have all instrument, including luminous laser, navigation system, NAR monitor, every advanced instrument. Thank you.
Thank you, Tushar sir, for being here in spite of all your busy schedule. I know you conduct a lot of workshops. I think you conduct one workshop every month, probably. So now Dr. Hitesh is other jack of all arts in ED. He does everything, he does even the endoscopic MVD. So, Dr. Hitesh, can you introduce yourself?
I am Dr. Hitesh Patel from MORBI, Gujarat. I have private practice since 2007.
Okay. So I think you do all your work in your private practice.
Yes, sir. I am in private practice only.
So it's my, privilege and to have all of you. The audience are really lucky to have all of you here. And maybe with that, we can just jump on to the panel discussion. So it's on difficult scenarios. And I would like not to have a panel like in the left corner image and very hot panel discussion or a very heated argument. Maybe we can have something, a fruitful panel discussion. So, and since the time is limited, my talk is focused only on inflammatory pathologies or sinusitis surgery. I don't want to jump to non-inflammatory pathologies and tumors because that's too elaborate and we cannot complete that in this limited time. And coming to the difficult scenarios, I always feel that we should classify it like that, the pre-op, intra-op, and post-op. And one of the most difficult scenarios is your pre-op challenge. So, is there some background noise somewhere? Okay. So, one of the most challenging things is the pre-op decision making. So, let me start with probably Anthony, sir. What is your most difficult pre-op challenge in endoscopic sinus surgery?
For the pre-op challenges, recurrent surgeries. First thing is recurrent surgeries, because the amount of endoscopic sinus surgery is done for a CRS nowadays is coming lower and lower with all the knowledge about the maximal medical therapies and the medical management and the load of steroids and the steroid impregnated nasal washes. So once you are decided to operate on a patient, the patient has got a polyps, or a patient who has got a recurrent disease with osteitis. It's very difficult for that's the most challenging situation for the surgeons.
Okay, that's a lovely statement. I think I would be coming to that. Is there any difference in opinion, Ramandeep sir? Is it the same or something different for you?
More or less the same. And another scenario which is difficult for me is pediatric age group. Because,
Okay.
the compliance is not going to be the same as an adult. There are going to be no nasal douching, nasal washes. Kids are very, very difficult. I mean, some kids are very compliant, but majority of them are not. And then many of them would have associated cystic fibrosis. So that is a nightmare, to treat those patients.
Mm-hmm. So how often do you see the cystic fibrosis patients?
So as protocol, any pediatric patient coming to us will be sent to our advanced pediatric center where they are worked up for cystic fibrosis. And we do get a decent number of cases. Then your surgical plan changes, the kind of surgery you do change, it changes because you want to expose as much as possible to be, able to do a better surgery and reduce recurrence. But no matter what you do, it's a child. Post-op examination also is very, very difficult, let alone trying to suction out the secretions in a 7 or 8 year old. Follow-up is very difficult. So that forms a nightmare. With adults, it's okay. Because adults can be compliant or non-compliant. The non-compliant ones will come back with the recurrent disease.
That's true.
But the compliant ones who understand that nasal washes are very important, and the surgery is not the curative, it is actually the medical management, and the surgery is just done to open the sinuses wide so that steroid douches, as Dr. Anthony said, can be can go up to the sinuses. Another subgroup I worry about is the ones who have preoperatively not responded to steroids.
Mm-hmm. So that's a lovely statement. Maybe Tushar sir, Dr. Pavan, any difference?
These three, one just point, in case of children, pediatric age group, I have seen a lot of patients coming to us with CT scan, basically chronic rhinosinusitis, and patients also, interested to do the sinus surgery. But I have seen a lot of patients with huge adenoid, nasal obstruction. If you do adenoid correctly, and nasal wash correct, and nasal spray, intranasal corticosteroid, and nasal spray also mometasone, and definitely patients improve. But patients party also anxious about the chronic sinusitis because they have done the CT scan and shown the lots of secretion in the sinus cavity. That is I think in my experience, that is not required the sinus surgery in case of children. And also with pressure of the party, I have opened some sinus cavity. I have seen nothing. It's a good antibiotic, good nasal wash. And if you do the proper nasal obstruction correction, means adenoid surgery, and then patients will be absolutely fine. That is also a pre-op challenge in case of...
I think even most guidelines, like the EPOS guidelines, also say the same. So adenodectomy first and only then Fess on the second sitting, right?
But Vinod, many surgeons in the West will also do a balloon sinuplasty. They will widen the maxillary antrum, give it a nice wash, and get and done it over with.
Okay, for the pediatric patients, sir?
For the pediatric patients, yes. Once they are doing an adenodectomy, they do balloon. I mean, they don't do the full house routine procedure, just a balloon sinuplasty, because maxillary sinus I mean, just widen it, give it a nice wash, and
Okay. That's a good idea. But then in India, it's it's very difficult.
no,
Also,
we don't do it. I'm just, even I haven't done it. This is what I'm quoting from the American Academy. We saw a few lectures on surgeons doing it.
The problem with the pediatric patients are the surgery is canvassing surgery is easier, but how are you going to give the post-operative care?
Oh,
Exactly.
that's
We
a problem. That's a
spoke
real
about
problem.
See,
So-
patients sit in the clinic, and once their turn comes, they will start crying. Bring them, do whatever you want to do, and then put them out under anesthesia or not. Once they go, they'll be very happy. So
Yeah, that's true.
they very difficult for them to convince.
Professor Omura, you have something to say on that? Dr. Omura, Professor Omura, are you there? Professor Omura? Okay.
And another, just one point.
Yeah.
Another preoperative challenge, I feel,
sure.
lots of point is there. I feel if you convince the patients, take some course of antibiotic and course of steroid and nasal spray, after that patient thinks does not require surgery also. This is also preoperative challenge. Because after that good medicine, after that you want to do surgery, then patient does not want. But in the acute case, patients want to do surgery. That is also preoperative challenge for me.
You see a patient with opaque maxillary sinus, and you take up the patient for surgery within 2-3 weeks, and if you open up, nothing will be there.
Okay, that's true.
Most of
Hitesh, Dr. Hitesh, anything
most of the physicians do CT scan during active phase. So it is very difficult to explain the patient about the disease. Okay. So always do CT scan after a course of antibiotic and steroid.
Really.
Okay.
One more point, Vinod, I wanted to make. It is the patients who are elderly patients who are there on aspirin or some blood thinning agents, and they do have severe hypertension, and that is not getting okay. So that is a nightmare to me. Like those patients, how I'm gonna deal intraoperatively. It is a big problem because you have to start back on aspirin immediately after surgery somehow. So these are some patients, and AFRS is one nightmare for me. Like preoperative, it is a challenge always because most of the patient will get some disease later on again and again. So AFRS is something which I have to tell them that you have to come back to me within 3 months or maybe every 6 months to get it cleared again. A bit of.
Maybe that's why I have the next question actually. The biggest challenge for me is the patient will come like that. Sir, everybody says he'll recur. There is no use in doing a surgery. So how do you canvass these sort of patients?
I think in my books, it is the quality of life, I tell them. When the facilities are available there, we can remove the disease and maybe no remission, but still you are going to get a good quality of life. First thing is that. Second thing, somehow you have to tell the patients the complications. If you don't get it done, it might spread to orbit or maybe it can erode the bones or something like that. So you have to tell them the sequelae of not operating or leaving the disease behind and the quality of life issue. That is something I tell them.
Because already there are the studies in the Google which says like after 12 to 13 years, most polyps will recur. It's even like, there's 98% of polyps can recur if the counts are like this. So they refer all these Google sort of things. And then they come to you, sir, it's like that. Even Google says like that. So what do you say, Tushar sir, anything from you?
Yeah, that is very correct. I counsel a patient 3 ways. I will do good surgery. So the recurrence depends on the surgery and follow-up also. If I do the good surgery and medicine will work, so I facilitate, it is a medical disease basically, and I will do the surgery to reduce your symptom, and then follow-up also essential. Some patients coming after 1 month, okay, fine. After then stop. After 3 years again coming, and then this volume change is there. So this is not possible. So if I do good surgery and if you are responsible, you not good follow-up. So both way win-win situation. If you're interested to maintain, definitely we'll do surgery. Definitely there is a chance of recurrence. But if I extend the recurrence after 20 years, 10 years, 12 years, that is the benefit. Quality of life will be improved at that time. So surgery required at any cost.
Okay. So, Professor Omura, are you there? You left?
Yes.
So, Professor Omura, any comments from your side? Because see, the patient says that it's going to recur. Even the Google says it recurs. So, why is surgery required?
Yes. It's
So,
yes. Yeah, nasal recurrence
Nasal
ratio
polyp.
is 90. Our recurrence ratio is basically 70%. I don't know,
70%?
30% of the patient are recurred.
Okay.
Yeah,
After
and for that cases, we just recently we just show the operation or bio
okay.
like medications. Dupilumab, something like that. And so recently re-surgery, the ratio of the re-surgery is quite become lower and lower.
Okay. So, Anthony, sir?
Yeah, actually, when I started doing sinus surgeries, it was only septoplasties and antral wash and intranasal antrostomies. So then, once I started getting endoscope and started doing Fess, we do antrostomy and a part of an antroectomy. Those things, when the patient comes and talks like this, we will no, that is different antral wash or things like that. This is, but now the 20 years made Fess is the same failure rate. So important thing is I don't give them high hopes. First thing.
Okay.
We tell them you have to catch infection often and it does very soon, like other people. So you operate it, you also will become like anybody else. Still you can catch infection, but it will become, it can be treated easily. That's the only idea of surgery. So if you give, you will have.
So, Ramandeep, sir, anything different from you? It's the same?
It's the same, and it also depends on the kind of practices we work in. This question, for us, where the waiting times are horrendous, and patients usually don't tend to ask too many questions. Yes, they do come up with whatever it reoccurs again, and you just have to nicely, just explain to them, yes, this disease is known to reoccur, but if you keep on regular follow-up, we might give you a few cycles of steroids over the next few years, or steroidal douches, or intranasal steroids, and we can suppress the disease. We cannot eradicate the disease.
Things are different.
Do understand. It's how you communicate with.
Things are different for people like me and Tushar sir, Hitesh, who are working in.
Yes, actually, Tushar sir made a very valid point, because this has come up in many times, that you give the patient pre-op steroids, he doesn't come back. Because they feel the disease is opened up, and then they start abusing steroids. Whenever there's obstruction, they'll take steroids.
So do you no, something is going on the brain, I think. Dr. Omur, I think your mic is okay. Yeah, there's some background volume from yours.
No, this is not my Gautam's mic, I think. This is not my mic.
Okay, so Gautam sir, can you mute your mic, sir, please? So so what about this? All these phenotypes that okay. So do you follow all these phenotypes, endotypes? Are they important in your practice? Do you really follow this, or do you do some particular workup for all those things? The phenotype, endotypes, are they important? Do you classify? Do you do some pre-op investigations in your practice?
You asking me?
Yeah, I'm asking you.
Oh, okay. No, how to say? Basically, no.
No, you don't. Okay.
Yeah.
So what about Anthony, sir? So the phenotypes and endotypes, do you classify this?
With the polyp, we'll think of surgery early. I mean, in the sense you see the patient with polyps, one of the main line of treatment will become surgery. But without polyps, unless the patient goes for a complication or a recalcitrant treatment and you give a maximal medical therapy, then take CT scan. In spite of that, you see areas of obstruction in an osteometal complex or in the mucociliary pathway. Only those patients with a proper guarded information will think of surgery. But polyps patients, they might require surgery at any time, and the chances for them to recurrence also is high. But to deliver steroids and other washes to the sinuses, you got to do surgery for these patients.
Okay, Ramandeep sir, is the same or any difference in opinion?
Well, of course, if there's a thesis going on, then yes, all this is followed. For routine endoscopic sinus work, we don't follow.
Okay.
Because it is not the end all for everything. There is a lot of if you read the Practol by the European Academy, you'll see the strengths and weaknesses of all this classification.
Mm-hmm.
But we take polyps biopsy and look for the eosinophil infiltration. This doesn't have a big role in the pre-operative assessment of surgery, but post-operative steroids and post-operative management, this is very, very useful. Particularly the eosinophilic type, we'll have definitely have a tendency to recur back.
So, Tushar sir, Dr. Hitesh, Dr. Pavan, anything from your side? Same or?
No, sir.
There's some
Same.
difference? No, same. Okay, now let us jump to the surgical part now, right? The surgery is more important. So, let's go sinus by sinus. So, the maxillary sinus, here comes a very common question. How wide do you open the maxillary sinus in chronic sinusitis? Do you just remove the uncinate process or you widen it? If you widen, how do you widen? Do you widen anterior, posterior, superior, inferior? So what is your protocol like? Let me start from probably Dr. Pavan.
Yeah. So, if it is nasal polyposis or just chronic rhinosinusitis without nasal polyposis, I'll remove the uncinate process and that's it. Just suction the things inside and job done. But if it is AFRS, if it is allergic fungal rhinosinusitis, I'll need to have a wider opening because the role of post-op douching is more than my surgery in AFRS and the CRS with polyposis. So in that case, I have to widen it a bit more. Where do I widen it? I widen it inferiorly a bit. Entirely, I don't come ahead because NLD is there. You can injure that. Superiorly, you don't go because your lamina is coming down there and orbit is there. So posteriorly, you can do a bit with the true cutting forceps, anterior true cutting forceps. But you have to be careful for the anterior branch of the sphenoplateral artery, which bleeds afterwards in a few patients I've seen. They come up.
And the posterior period. Yeah, that's true. Yes.
So that is an important thing. So you have to buzz that off and then do this. So this is how I follow. AFRS, maximum widening. CRS with nasal polyposis, medium. If it is CRS, no extra widening, only uncinate process removal and job done. Okay, so that's lovely. Tushar sir?
Basically, according to pathology, if too much pathology is there, maximum widening is required basically. If pathology is less, you may open the maxillary opening will be less.
The same like what Dr. Pavan told, right?
Yes.
Yeah. So Dr. Hitesh?
Same, sir.
Same.
Type 1 in case of polyposis, type 2 in case of fungal sinusitis, very wide opening, and type 3 and 4 for tumor approach.
So what do you mean like by saying type 1, type 2, type 3?
Type 1 means we have to wide the antrum superiorly up to the inferior level of orbit, inferiorly up to the inferior turbinate, anteriorly up to NLD. Okay. Routine case is type 1. In type 2, up to the wide, huge opening up to the posterior wall of maxillary sinus, like Dr. Pavan sir said. Okay. And type 3 means removal of posterior half of the inferior turbinate also. Okay, and type 4 is our classical medial maxillectomy.
Okay.
Modified
So-
Denker's.
Modified Denker's, yeah.
So I think you have some video on the NLT damage during, right?
Yes, sir. Yes, sir. I have.
So maybe towards the end we can play that. That's
Okay, sir. Okay, sir.
right. So what about Ramandeep, sir?
For a chronic sinusitis, size of the middle meatal anatomy will be depending upon whether there's an accessory osteum or not.
I will come to that. That's a lovely thing.
We
Okay,
know the osteum, and there is no big pathology inside that everything looks fine, we don't do anything. Another important thing is we don't remove all around. If you remove all around, it becomes smaller. And second thing is you make a huge osteum, doesn't prevent the patient not having sinusitis. But it is very useful for douching purposes. But because all the lymphatics goes around the osteum, when you include all these osteums, there is a lymphatic stasis and still infection can be there.
Okay. So maybe before I come to that, before I come to Ramandeep, sir, may I play this video? See, this is what I generally do for recurrent cases. It's called nasalization. This right side, so that's the right middle turbinate, and here we just chop off this part of the inferior turbinate. We take a mucosal flap from the inferior turbinate. We chop the inferior turbinate like that, make 2 cuts there, and with the Colorado, I take a mucosal flap. I base it inferiorly like that, take the flap down, and then I drill off all this bone so that I get so that's now the nasal cavity and the maxilla is in line. They are on the same level. And then I put the mucosal flap back. So this is what actually some
Type 3.
people do for
Type 3.
recurrent cases. You call it type 3? I don't know.
Yes.
So this is what I call nasalization of maxillary sinus. So I think, Anthony sir, in your view, this has its own demerits, right?
Sorry?
So it has its own demerits when I widen it like that. That's what you're saying. The
That's right.
lymphatics.
Yeah, in fact, even if you do a wide middle megalantrostomy from the anterior border to the posterior wall, from the orbit to the level of the almost attachment of inferior turbinate, there is some amount of stasis will be there. The mucociliary, the clearance will not be as good as doing minimal damage to the maxillary sinus osteum for a simple sinusitis.
Simple sinusitis. So in a recurrent cases, we can do like this.
Yes, we got to do this. That is, make it wider so that if it comes.
Ramandeep sir. Sorry, sir. You may continue. Please, sir. Yeah. And sir, you can continue. I think you're saying something.
Management entirely depends upon the steroid spray and the washes. For that, you got to make it a huge middle megalantrostomy. There is no other way.
Okay. So, Ramandeep sir, is it the same or something different from you on your side?
If you ask me, there is no one correct answer for the size of antrostomy. It's agreed, it's completely your practice. When you are beginning out as a new surgeon, opening up wider might help you to clear the disease. Like Pavan was saying, AFRS. Now, AFRS has an inherent habit of going deep into the maxillary antrum, and to remove it or to flush it out, it takes some amount of large opening of the maxillary antrostomy. And like Hitesh was saying, the type 1, type 2, they are that's also a classification system. In type 1, it's 1 centimeter, type 2 is 2 centimeter. But for and if you're doing a transpterygoid approach or tumor approaches, of course, you have to open wide. The posterior end has to be taken up to the posterior end of the maxilla. So that is also that's a very different scenario. But there's a very interesting article by Brahman et al. In which they studied xenon gas sheep models. And they said that in ventilation, if it's a normal disease, then opening a sinus 2 to 4 millimeter, and they compared a 6 to 9 millimeter opening, there is not much difference in ventilation. So the type of disease you are, dealing with, surgical expertise, and of course, what approach you are trying to, get, it's going to decide the kind of antrostomy you're going to do.
So maybe this slide. Professor Omura, can you comment on this CT scan? How you approach them? Any precautions you take in the maxillary sinus surgery in this patient? Professor Omura?
Yeah.
Your comments on the CT scan.
Yeah, so there's a very, very small maxillary sinus, and the how to say, the flow of the maxillary sinus is elevated to the
Okay.
middle. If you compare to the left side, they are middle of the, how to say, middle of the height.
So it's a hypoplastic maxillary sinus, right?
Yeah.
So how do you do the uncinectomy in this patient? The same technique or something different? I think you do your
Especially the, how to say, vertical part of the uncinate process, and that is also the, how to say, this is a high atelectactic maxillary sinus, atelectactic the uncinate process. That is a very, very dangerous case of the, like dangerous cases. So you have you should not how to say, insert the knife to the
orbit.
Orbit. Yeah.
Because see, I can see the small cell
cases,
there.
you can access to through the inferior meters too.
Like that?
Yeah.
Okay, that's a good idea. So Ramandeep sir, your comments. I think there is a small cell also there. Halar cell. So yeah, so
this is the case. Majority of us, if we are not careful, will end up in the orbit.
Yes.
So your precautions, how do you, maybe Pavan, how do you?
Direction of the instrument, it has to be inferiorly. Trim part of the upper part of the inferior turbinate, and you will get an easy entrance.
You mean you trim here?
I'll
Right,
prefer
correct.
backbiting here. I'll prefer a backbiting forceps over here.
Okay.
Rather than using maybe a freers or whatever you want to take the anterior approach. I'll come from back. I'll take a ball probe to elevate the incident a bit.
Yes.
Create some space and then use backbiting.
But thing is, sometimes you just enter the cell and you're confused. It's a maxillary sinus or the. Okay. So you do the retrograde technique and not the anterograde technique. Is that what you're saying? Okay. Anthony sir, any comments from your side?
This is actually a type 3 hypoplastic maxilla.
So what is type 1, type 2?
Type, when there's a uncinate process, will be at the level of the lamina papricia. Type 2 will be lateral to the lamina papricia, while you have a appreciable amount of sinus. Type 3, you will have a small slit. On top of that, here you have something like a hala cell there.
Yeah, right.
This one. Okay. So that makes it very small. So what you do is the gap between the floor of the orbit and the incinate process will not be same anteriorly as well as posteriorly. So try to make a artificial middle metal antrostomy posteriorly and find superior border of the inferior turbinate. Start backbiting from there. Then you can find the natural ostium at that given space without entering into the orbit.
Okay.
That will be my technique.
So, Dr. Hitesh, anything from
sir, 70-degree? Sir, I would like to use only 70-degree endoscope in this case. Yeah, not 30-degree also, sir. Okay.
Okay, that's a good technique. Tushar sir?
Yeah, if you careful and definitely no injury will be there to the orbit, and just angle endoscope is the best way for this case.
Okay.
If you take the angle endoscope, then easily you will get the entry. Otherwise, if you are not sure, then you just trim the turbinate part.
Okay.
And it will be easy entry.
Maybe as Professor Omura said, you can go through the inferior meatus also if you are so confused, right? Yeah. So, how often do you see a circulus phenomenon and a missed ostial sequence? Dr. Hitesh, do you commonly see a? How frequent is it? No,
sir, not commonly seen, sir.
Not commonly. And Ramandeep sir, is it important, the circulus phenomenon? Is it very common or uncommon?
We do see it, and mostly even post-surgical, post-surgery also sometimes it happens. You've opened the maxillary antrum, but a fibrous band forms in the middle, so that the openings become two instead of a single one. I mean, just take them to the minor OT with a through cut, just snip that.
And even the accessory ostia, if the previous surgeon has not addressed the accessory ostia, he has not made a common opening of accessory and the primary os. Then and sometimes with the inferior medial androstomy also it happens.
Okay. See, this is actually, I'm doing a middle male androstomy, but then, see, with the 0-degree endoscope, I cannot see the accessory host this one. I cannot see the accessory host. Only once I change to 30 degree, I can see the accessory host. So, do you routinely use the angled endoscope when you do the maxillary sinus surgery?
Yes.
For maxillary and the frontal sinus, always we use the angle endoscope.
Because that was a classical teaching the process. Stamberger was you have to switch over to the 30 degree endoscope once you open the maxillary sinus. But nowadays people just use a 0 degree, and I see that sometimes even I miss the accessory hosting because that happens. So, Ramandeep sir, your comments?
Another common thing is people make one ostium and miss the natural ostium. That is more common than missing the accessory ostium. And we should always keep in our mind that Stamberger's criteria for the natural ostium, like it is not circular, it is oval, and it's facing not directly facing the middle meatus. All these things should be in your mind when you are doing a middle meatus antrostomy, because we can indifferently make an opening, then getting the actual natural osteum.
Okay. So, Ramandeep sir, your comments?
I think we can move ahead.
Yeah. So the next thing, probably how to remove the fungus. Do you use, see, this is a allergic fungal rhinosinusitis. So the fungus trapped in this alveolar recess and zygomatic recess. It's always a challenge for all of us, right? So how do you remove the fungus from these corners? So Ramandeep sir, so once you, even if you open the
this is exactly what we were talking about in the previous slides, that the deep depth and you have a fungal ball. Many of times we try to suction it, don't try to suction it. Your suctions are going to get clogged. You're going to be opening the suction up, putting it in repeatedly, and it's going to test your patience. Easiest way is with a angled suction, just dislodges a bit and then just let it go with hundreds and hundreds ml of saline. All this is going to come out. Medtronic also makes what's called a hydrodebrider, which is a high pressure, ventilation jet of saline, which can help pushing these away. But again, that's expensive, and that's nothing extra what a 50 ml or a large syringe with an angled suction attached to it cannot do.
Okay. So, Dr. Hitesh?
Sir, I always use half piece of Merosil, sir.
Half piece of Merosil.
Half piece of Merosil and curved suction, and press the Merosil with curved suction, and then give the saline post. Repeatedly, we have to do this.
Okay.
You have to take a big Merosil.
Sorry.
You have to take a big Merosil, no small.
Not Merosil. So, but I generally use just gauze technique. I just take the gauze.
Yes. I also.
You put the gauze. Yes, sir.
I also use
put the gauze. Automatically, all fungal will be automatically removed.
I push it in the maxillary sinus, fold it, push it inside, and then hold with the forceps and do this screwing like movements all around.
Like that, you see? Is
and
it the same? Okay.
Yeah, the way you are doing, yeah.
Okay.
This is the second video. It's a previous. Yeah.
Okay. So you use the gauze more often than the Merosil, right?
Yes.
So you also. So I think already Ramandeep sir told about the irrigations. So generally we just use the 50cc syringe, and we don't have the Medtronic's now comes with a hydro irrigation, right?
Hydrodebrider, correct.
Okay, but then this even 50cc is also good enough.
Enough. It works well.
It works well, right?
Do you use diluted hydrogen peroxide with betadine and with water in mild dilutions and put inside, which will dislodge the fungal balls and can easily take it out.
That's also a good technique. You can use some hydrogen peroxide or maybe the soap solution or the baby shampoo. This can dislodge the fungus.
And in spite of that, if you can't reach the alveolar recess, you can still do a pre-lacrimal approach, make a window, and you can push this inside and take it out.
Okay, so this is one particular case where we are doing a pre-lacrimal approach. I think you do that if all other techniques fail, right?
Yes.
Okay, so we just make an incision like that above the inferior turbinate, and then chisel up this bone there. Okay, then you put the curved section inside. So that's a prelacrimal window, that's a nasolacrimal duct. And now you get the approach to the corners, like the alveolar recess. And I think nobody told about the inferior meatal wash. Does somebody practice that? Like that you put the suction into the inferior meatus or debride the curved debride blood into the inferior meatus and then do the debridement? Hitesh?
No, sir. I do
Couldn't do that.
CFT sometime.
Okay.
No, actually, all these things are all we reserve only for the attachment of an androgonal polyp.
Yeah.
Okay. But rarely I had to do this prelacrimal approach for the fungus in the alveolar recess of maxilla.
If it is larger, there's something that will not come at all. Actually, if you are very busy, like you know how it will be in Madras Medical College. We tell them just leave the fungus, keep watching, it will come out. But the problem is outside you can't bleed like that. So you got to can't reach that place in spite of your RAD 120 blades and things like that. Then you got to do a prelacrimal approach.
That's it. Okay.
I've
Yes,
used
sir.
in a couple of patients the canine force androstomy for these cases,
Yes.
through which you can wash and it comes out through your white metal.
White matrix. Okay.
Open,
Okay.
yeah.
Right.
That is one approach you can use sometimes.
Okay. Professor Omura, anything different from your side? I think you sometimes do the Denkes window. You just do the Denkes approach and we make a small window, right? Professor Omura?
Yes, yeah. But basically for the fungus, I don't do the Denker procedure. So
Okay.
I try to preserve everything. So even I will add the procedure until maybe prelacrimal approach.
Okay, so you even don't do the prelacrimal approach.
Yeah.
Okay. So how do you get the adamant fungus which is lodged in the alveolar recess? What is your trick
Yes,
to get that?
as a method of the gauze, I just try to
The gauze dissection.
that is I'm very interesting point. I try to remove to avoid the to avoid the damage of the fungus. So I try to remove as a unblock. Like if you don't penetrate the fungus, then it is
I
easy
know.
to.
So you go around the capsule of the fungal ball, right?
Yeah, exactly. And especially
sometimes
Not always possible.
Yeah, exactly. But
Okay.
that is my interesting point. Like today I can remove completely. So I'm very happy. Something like that.
Okay, right. So maybe the next slide. This is actually one interesting one. You sometimes get cases like that, a small sort of recess, deep recess in the alveolar like that. And it's going actually well below the level of the nasal cavity like that. So do you do a cardiologic approach or you go for some other approach for these sort of cases, say fungus lodged in a recess like that? You can see there's a sort of septation there, it's a deep recess, very narrow recess.
Prelacrimal this out, no?
Hitesh?
Canine fossa.
Sir,
Canine fossa approach, yeah, canine fossa
approach,
approach.
sir. I always do canine
canine fossa. I think Hitesh, you have a lovely video of this sort of alveolar recess.
yes, sir. I sent to you. Yeah.
Yes. Okay. Maybe now this scenario is a very tricky scenario. This patient had a orbital blood fracture a couple of months back, and now there is maxillary sinusitis. So how do you approach this case, Ramandeep sir?
What is the complaint of the patient?
Cheek pain, discharge, cheek pain.
I mean, that can be a spin-off of the, orbital injury or a facial trauma also. Many patients will live with sinusitis like this and it will not do anything. But if there is a muscle entrapment and the patient having diplopia or other things, then of course you can go ahead, repair this and clear the maxillary antrum on its own.
So for the sinusitis, you can just leave it like that?
Yeah. I mean, if the patient is having no complaints, this patient will present to us for trauma, not for sinusitis. That's for sure.
Okay.
Because it is, with the blowout like that, you can see the contents in the maxillary antrum. A major part of the wall is gone. I mean, I'll need to see a sagittal scan to see how is the damage anterior to posteriorly. You can just, it's not that we would go and just clear the sinus and not do anything for the blowout, because if we don't, it is going to come back again. That's a massive chunk of tissues that is lying in the maxillary sinus.
So how do you go if the patient has like chronic nasal discharge and the patient has some sinusitis complaints? So how do you operate the sinus then? You do a combined surgery? Yeah.
I would probably combine it. I mean, if he has diplopia or, the eyeball is kind of gone in, I would take depending on how it's anterior posteriorly, we'll probably take help of my ophthalmology colleague. They have those blocks, the plates, biopore plates, which they insert. And once that is out of the way, it's called a combined approach. We have a few cases like this, which we have published. And then just drain away the maxillary antrum, a nice wash, and it needs ventilation. Sinusitis is happening because there is blockage of ventilation.
Okay. So let me come to Andy, sir. Let me put a tricky question for you, sir. So suppose this patient is not interested for any orbital repair and you have to drain the sinusitis. So how do you go ahead, sir?
Sorry, I don't get you. This patient doesn't have?
The patient is not interested for an orbital blowout fracture repair and he just wants to cure his sinusitis.
The same thing. No, that is, you got to use an angled scope, do a good bunionectomy, check for the wall. I think the wall is intact. Or remove a part of the superior part of the inferior turbinate, find the place, go and take it out.
Okay. So any difference in opinion?
Yes,
any difference in opinion from anybody?
Just if patient interested, clean the sinus, definitely you clean, but at least keep Merocell pack within the maxillary antrum at least 5 days or 6 days to prevent any prolapse or something. Yes.
Okay.
This type of case I have done few days back, basically.
Okay, maybe you can also put a Foley's catheter and inflate the Foley's balloon into the maxillary.
Yes, also. But we have put
sorry to interrupt, Vinod, but why would we expect a prolapse? Why would it happen?
No, basically that patients have slight bit of, you look, this patient also, so some trauma is there, no? If I remove, there is a chance of lower part, slight bit of down will be there, no? So by chance, any support system from the pathology, so if I remove, then there is a chance of slight bit of prolapse.
I mean, so if you accidentally during surgery remove some support, that's what you mean, right?
Yes.
So if you accidentally enter and dislodge the bone which is there.
Yes. That's what he's saying. Yeah.
So support to the bone also required at that time.
If you remove this bone accidentally during surgery, because it's very tricky surgery, you can just poke inside the orbit accidentally, right? So I think maybe Omura would go through the infirmiatus. Professor Omura, this case.
Yeah, so I prefer. Maybe all of you don't understand my approach, but the Dharma approach, that is a direct approach to the anterior and the lateral wall of this maxillary sinus. So it means how to say, you can access the anterior wall of the maxillary sinus by endoscope.
I think I can explain that. Probably you put the Denkes. Yeah,
no.
Right?
Denkel is you have to remove the piriform aperture.
But you put the
kind of endoscopic cold-well look approach.
Or the same Denkes exposure with a small window there, right? Preserving the piriform aperture. Is that the same?
So preserve the piriform aperture, but just open
a
up the
hole
of the exactly. That is a very nice approach to the if the orbital floor going down from the anterior part, then the Dharma approach is a very good way to reconstruct for the reconstructions.
But how do you maintain the ventilation?
Yeah.
Because in your
that is what I said. अगर उसको नहीं करोगे तो वो फिर block हो जाएगा.
Yes.
Ventilation and release. So I would rather prefer type 3 uncinectomy in such case. But
Maxillary fungus.
Nitesh
No,
told us.
Ventilation means
Maybe
maxillary
rem-
ventilation, right?
We can
Yeah,
remove
that's
the
maxillary
we can remove
ventilation,
the
Yeah,
yeah.
so
posterior half.
basically, I don't use the only Dharma approach. I combined with the Dharma and the preac approach. So you can how to say, you can make the connection through the through the natural stem
As
of the
as
maxillary
Vinod sir,
sinus.
you showed nasalization of maxillary sinus.
Yeah,
I think
yeah.
it is the
Yeah.
answer. I think in this
It is
case.
the answer for this thing.
Yes.
Ah,
Yes.
okay, okay. Okay, that's a radical surgery, but probably that's a
But in
option.
this
Yeah,
case,
yeah.
what will you
Okay.
do?
Okay, that's right,
Yeah,
that's right.
that is
Yeah.
the answer only.
If
Sir.
you got to persuading to go for the blower fracture repair.
Ah, okay.
Tell you
Right.
advantages. And two
No,
things to tell you know,
yes. Probably we can convince the patient about the repair of the blow-up fracture and then go with combined procedure. That's the best possible way. But then, or else probably I never thought of the nasalization, but that's a good idea. It's a fantastic idea, I think, for this patient.
Yes.
Yes.
so the cyclone is coming near, so there is a heavy rain here. One thing. Second, you have fully formed a skull base surgeon, so thinking of modified dentus for almost all cases.
Okay. No, but what Omuro said is also right. You can do the window there, prelacrimal, remove the entire uncinate process and inferior turbinate. That's a good way, but then maybe I wouldn't do like that. And I never thought about the nasalization, but then that's a good way for this patient probably. And
Yes, sir.
so let's go to the ethmoids now. Let's finish the maxillary sinus and go to ethmoids now. See, this is the pre-op scan on the left side, and the right you are seeing the post-op scan, and you can see this is a good surgeon. He had done all the removed entire septations there, but then again for him there is some complication. Can somebody comment on this complication, and how do you avoid that? Ramandeep sir, I think you're staying silent for some time now. How do you avoid this? Okay. How do you avoid this complication?
I honestly, I really don't know what's happening. If you can.
Can you see the middle turbinate there?
Yeah.
Somebody did a good ethmoidectomy. It's a good surgeon. It's nicely done.
Oh, you mean it's lateralized?
Yeah. So how do you avoid that during your ethmoid surgery?
So what was older times was called the Bolgerization. It's called a controlled synechial technique in the modern terminology. Part of the lateral middle part of the middle turbinate is made bare, and the septum, and they're made to kind of stick together. But that being said, even in the best hands, turbinate lateralization is one, and synechia are one of the commonest post-operative Fess complications. If it happens, you have to end up opening it. Otherwise, there's going to be disease formation. There's going to be lack of drainage. Your douches are not going to go into the nasal cavity, and it's going to happen. So as protocol, we do a controlled synechia technique in all patients. And if we see the space is limited, we just trim like 2 cuts with a through cut, the interior part of the middle turbinate.
Yeah, okay.
I think second point, what we could do is we have to preserve the horizontal attachment of the middle turbinate there. That is something like as a pillar to make it rigid so that it doesn't come floppy later.
You mean that a shelf of bone there like that?
Yeah.
Okay. Right. Maybe Tushar sir? Yeah, Tushar sir. Yeah.
Yes. With all efforts, sometimes I have seen steel laterization. I think this is the most happening and most unhappy moments of the surgeon. No, done good job, but laterization of the middle turbinate. To avoid, we have done everything: vulgarization, stitching, gel foam placement. Still, sometimes there. So that is the happen, and also I think checking of there after follow-up is very important. If you think this problem is there, then I now in my institute we do now, if middle turbinate not stabilized, lower part of the middle turbinate I sacrifice.
Yes.
Then problem slight bit of less. I think this is my experience.
Okay.
You share definitely your experience.
Anthony sir, your comment?
So one is this is for a chief, this is the ideal scenario to picture your juniors, because usually this suction clearance, when they don't do it properly and the mucosal degradation is not there, this happens. Second thing is, what I do is I keep a Nerocell pack in the middle meatus for 5 to 7 days. So this will you take out the pack, the chances for mineralization is little less compared with the normal cases. And when you operate, you got to be very meticulous on the mucosal injuries and don't injure the basal lamella on its lower part so that it will have a little bit of stability.
Okay. So let's go to the next scan now. See, the scan like that, a breeze, orbit and skull base. So maybe Professor Omura, how do you proceed in this patient? If you have a scan like that, there's an orbital breach, a skull base breach. So your tips in doing ethmotic in this patient for the younger generation?
Yeah, so this is my favorite. And yeah, but firstly, so for the draft procedure, yeah, so for this kind of patient, you have to use the drill, right?
All India and half India total marisle to koon sono rasile?
Some background noise.
Yeah, Dr. Gautam.
Okay. Gautam sir.
But anyway, okay, let's maybe you can hear my voice, right?
Yeah.
So drill. So for the drill, then how to say, the amount of the water is very, very important.
Okay.
And when you use the drill of the Medtronic company, then the volume of the water, the default is maybe 5 millimeter, 10 millimeter, something like that.
Okay.
But if you use a M5 drill, then if you increase the volume until 80,
okay.
So if you increase the 80, the irrigation is a much, how to say, bigger.
Okay.
Then the water just wash out the bone, everything. So you even for this patient, the bleeding comes out from the tumors, the ossifying fibroma. So just comes out the bleeding, and also, yeah, but the water just wash out everything, and you always can detect the behind the bone.
Okay.
Right.
So even you use plenty of water,
patient,
right?
You have to see the periosteum of the orbit. You have to see the dura. You have to remove all of the bone as much as possible.
Right.
At that time, if you increase the volume of the water, then it's very, very helpful.
Okay. So Pavan, this probably is, say it's a fungal allergic AFRS, and how do you prevent walking into the orbit in this sort of patients? How do you prevent orbital injury during your surgery, Pavan? Or you're not audible, you're muted, I think. You are muted.
First thing, I'll use navigation in this patient. So
navigation system
is one thing which I'll do by bit, cell by cell, I'll go. And I'll see it again, wash, see it again, then open up one more area. So bit by bit you go, you keep medial, inferior, and then go bit by bit. So this is how you can approach this case. And I think it is doable. It is doable.
Okay, right. So say this patient is blind on the left eye. Say this patient is blind on the left eye, and right is the only seeing eye. Will you operate or not?
Yes, sir. I will, of course, operate, sir.
You will, of course, operate.
Yeah,
okay.
Yes, sir.
So,
and sir, it is a
what
case of,
makes you so confident here?
Yes, sir. It is a case of.
So, what makes you so confident in operating this patient?
Because sir, it is a case of,
right?
It is a case of fungal sinusitis, sir. So we have to operate, sir.
Yeah. Okay. So, but patients only seeing eye, is the right eye. So, if something happens on that eye, that's finished. It's blind on both eyes. So, how do you prevent an orbital injury here?
Sir, as Dr. Pavan says, we have to remove bit by bit fungus and near the orbit, near the area of the, sir, in case of fungal sinusitis, always dura and periosteum is intact. Okay.
Intact. Yeah, that's a good point.
It is a very important point. Okay. So we have to dissect as in maxillary sinus. We have to dissect with merosil and pressure with suction tip and merosil. Okay. In that important area. I think most of the recent, sir, that patient's video of inferior alveolar recess cell, same
yeah.
same thing,
Same, right,
same CT
right,
scan
right.
was there. Okay, so I
Okay.
had removed fungus over the exposed lamina periosteum with a merosil resection. Okay.
Okay. So, Ramandeep sir, I think it's do you have some difference in opinion or the same?
So more or less, see, if this is AFRS, number one, we don't need to worry about it too much, because it is very like AFRS is pandemic in our area. That is what we majorly do.
Okay.
And it is very, I don't remember the last time I've seen when there's a periorbital breach.
Okay.
And it can go through the lamina papracia, it presses the eyeball, patient presents with massive proptosis, but the periorbita is resistant to AFRS. So once that area is opened, once you gently push the eyeball in, the muck comes into the nasal cavity.
I mean, you push the eyeball. Okay. Right.
Yeah,
Okay.
just push the eyeball. The muck is going to, it's just going to mobilize and move into your field, and you can just suction and wash it out. Secondly, like you were asking, if someone is not confident, again, all these cases require graded, training and approach. If I'm a younger surgeon or a novice, this is not the first case I would be doing.
Okay.
You need to realize that this is a tough case, because bone is not there, and with the powered instrument, it's easy to go through the periorbita. If you do that, fat is going to come out. The disease will be even tougher to take out than what it was primarily. So take a senior's help, or refer it to a patient or to a surgeon who can, do it better.
That's a very nice point.
Three of us are doing cases like this. I know Pawan does a lot of these. So it's not something which is, not doable. It's a case. Yes, you have to be patient. You have to, give preoperative steroids so that there is a lot of shrinkage of the polyps and the fungal muck, so that it makes it easier for you to operate. Also, many times you would see that the skull base is eroded, and we get scared that the skull base, that's not the skull base getting eroded. It's majoritarily what we call partial volume averaging, which happens on CT scans. It's one of the artifacts of the CT.
Okay. So, Tushar sir, that's actually a lot of good comments from your side, Ramandeep sir. Thank you. So, Tushar sir, maybe these patients see revision polyp, and you can see the anterhythmal artery hanging there. How do you avoid a complication? Because you can always get a nightmare like that. So, what are your tips in avoiding an anterhythmal artery bleed in this sort of patients? Tushar sir, are you there? Are you left for the dissection? Or maybe Anthony sir, can you throw some insights here?
This is anterhythmal artery bleed. The problem comes only when you don't recognize it. And once it goes inside
How do you prevent it? How do you prevent a bleed in this sort of patients, like the artery hanging in the masonry like that, in a revision patient? How do you prevent the bleed, sir?
So remove all the polyps. When you go near that, you enter the posterior might find the skull base there. From there, you just come anteriorly, and be careful around that anterhythmal artery area. And if you already could locate the frontal sinus with the frontal fovea and the posterior skull base, in between that area, be careful when you are removing it. If you see artery, cauterize it first, and then you dissect it.
Okay, it's a good point. Have anybody got a complication like that? Hitesh, Dr. Hitesh, have you ever had a Pawan sir? Dr. Pawan, you got? Okay, good. How many times? Only once? Okay, so I got 2 times probably. And maybe
do you want me to show that picture of a canthotomy cantholitis?
Yeah, I want it. Probably I will just finish in another 10 minutes and we'll have the videos. Right. So, actually, one patient, I got a complication after surgery. I did the surgery, I left the OT, I saw the orbit. I was going back to my home, and then I got a call like there's a retrobulbar hemorrhage when the patient was coughing and straining. So even that can happen, Maybe how you manage that.
Yes,
the lateral cancer.
Problem. Okay.
Maybe can we have the video, Ramandeep sir? Can we have your video for how do you manage that? I can just stop sharing if you don't mind. Because nice to have the video now itself. Ramandeep sir, can you share your screen? Okay. There we
Ramandeep
go.
sir, please unmute yourself.
Unmute yourself, Ramandeep sir.
Ramandeep sir, please unmute yourself.
Ramandeep sir, your audio, I think your audio is muted. Okay. So anyway, you can see the retrobulbar hemorrhage there.
So we have done a canthotomy, but the procedure is not complete without a cantholysis. Even after cantholysis, the orbit was still tense. So and the pupil was becoming sluggish. So we went ahead because this is a tumor surgery we were doing basically, and you can see the cautery marks here. We were trying to cauterize the vessel. It was a no-go, and we went decided to go ahead with a canthotomy and a cantholysis.
We can't see that video. We are just
seeing the. Okay.
You cannot see?
Yeah,
No,
we are
just
seeing
seeing
your
your.
slide, vascular injuries in endoscopic and meniscus surgery with your name.
We were seeing the video before, yeah. Now we,
No.
yeah. Now we can
Now
play
you
again.
can see.
So we don't see the video.
Yeah.
You,
Now we are seeing, yeah. Now we are seeing it.
we can see that.
Again, go on. Yes, keep the slide again. Okay.
Uh,
Slide two, the video. Yeah. There we go. Yeah.
Okay. So we did so this procedure is not complete. It is canthotomy and cantholysis. Canthotomy is the cut we made to approach the tendon, and then we do the cantholysis. Even after that, the orbit was tense. I couldn't go. So we went in. This was a tumor surgery we were doing. You can see the cautery. I have been trying to cauterize the vessel, but it had retracted. It was a no-go. And we decided to go ahead with the canthotomy cantholysis. Even that was not enough. So then we did an orbital decompression because we were right there in the field. So once the fat is kind of pushed out, you can see we give slight pressure on the orbit and the fat pops out. That releases the pressure on the orbit. So same day, evening, you can see the cut, which is a couple of days later. That is about 2 weeks later. The cut has healed. And the eye is okay, and that panda sign has
So let me
gone.
ask you a question, sir. See, if you are still there in OT, would you straight away take the patient to OT and do an endoscopic decompression, or you go for a canthotomy and cantholysis?
Canthotomy cantholysis is always the the first, because that you can do in a pre-op also.
Okay, but then you are in the OT, you can just shift it like in the 20 minutes and do the surgery.
Agreed.
Also.
But then breaching the periorbita,
Okay.
removing the wall, it is an added step, and it is always stepwise. You still have a couple of minutes, and just do. And canthotomy cantholysis, it does not take very long. I mean, this was an unedited video. I mean, it's under a minute's job.
And
okay.
One more thing, you have to do it in pre-op or post-op because the time is important. If it is increasing so much, it can compress the optic nerve.
Yeah, it'll be gone. Optic will be gone then.
Optic nerve compression for a few minutes can be disastrous. So I think it is a good idea to do a canthotomy and then shift the patient in the OT.
Okay.
Yeah. And if it is the ward, then canthotomy cantholysis is the best bet you will have right there.
So you take some 2-3 vent plants, large vent plants, put between the perorbita and the bone from outside, and take out that they say keep the cannula, still you shift the patient to the theater. That will reduce the pressure a little bit after lateral canthotomy and inferior canthotomy.
Sir, I didn't get you. Can you come again? How do you put the vent plan like? You put the IV line into the orbit?
Vents and cannulas, large ones.
Okay.
Palpate the walls, bony walls.
Okay.
Okay.
So it's like
to the bony wall, and they take out that needle through the cannula. The few drops of blood will come out. So that you put 2-3 days, 2-3, and then shift the patient, because not always you can immediately take the patient to the theater. You can buy little more time. When you do a cantholysis and a lateral canthotomy and inferior cantholysis, in spite of the if it is tense, you can do that.
That's a good idea. Okay. So maybe you can just run through the next subsequent slides because we are running short of time. So let's come to sphenoid now. And you sometimes get patients like this. No, CT shows a dehiscence optic. I see all this bone is around is dehiscent. And how do you go ahead in this sort of patients? Maybe can I start with, is Tushar sir there? No. Maybe Pavan sir?
Yeah.
Okay,
So,
how do you go ahead in these patients?
The most important thing is, first thing is read the scans well.
Okay.
Second thing is always, this is a basic fundamental. You should be seeing the tip of your instrument always, whenever you are operating.
Okay.
Don't use the powered instrument laterally and superiorly in these cases. That is third thing important. And fourth is city navigation. That is, I think, important. So you have not to be blind anywhere and make it a wide opening. Do a good post-voidectomy, make a wide corridor, go there, do a good sphenoidotomy, a good wide open sphenoidotomy. Even if required, you remove the rostrum of sphenoid and make it a wide opening and do it.
Okay. Dr. Hitesh, any difference in opinion from your side?
No, sir, same. And use, I think, use merosil or ghost dissection there. Don't use instrument, don't pull any tissue over that area with forceps.
So I can understand that you do a lot of revision cases and somebody refers a CT scan like this and a patient to you. So how do you go ahead in this particular patient, this CT scan? Have a look at the CT scan. What is your next line of management in this patient? You straight away go for the surgery? I think I would come to everyone probably this particular question. This patient is there and you are asked to operate upon this patient and probably in a conference or you get this patient referred to you. So how do you go ahead?
So if this case is given to you in a conference, understand,
maybe a conference, okay. No.
Understand that the organizers don't like you.
Don't like you. Okay. So
okay. Second is what pathology are we dealing with? If it is AFRS, again, give a preoperative steroids.
No, you don't know. Just see a CT scan like that. You don't know, right? You see some heterogeneous opacity and a CT scan like that.
Right.
Okay.
So, like Pavan had said, open the face of the sphenoid wide because there is nothing on the face of the sphenoid except the posterior septal branch from the sphenopalatine artery. That is the only, and that you can cauterize, take away, drill out the rostrum of the sphenoid, make a wide opening like you do for pituitary surgery, and then start gently. If it's just a biopsy you're doing, you can start in the midline, pick a biopsy, don't go laterally as Pavan said. Secondly, if it is AFRS doesn't stick to the internal carotid or the optic nerves because the cadherins and adherents are different. They are they're different pathologies. They're not going to integrate with each other. Give a lot of wash, lot of cleaning, and always have the tip of your instrument in vision.
Right.
And I think, and again, experience, these cases are for experienced surgeons. We need to have insight to know what we are capable of doing and pulling off. Luck doesn't support you all the time. So that would be a message to the youngsters. And take a senior surgeon's help. I mean, it's not that these cases are not doable.
Okay. So any difference in opinion? It's actually a lot of valid inputs there. But is there anything more to add?
If it is AFRS,
Sir, you don't know. You just don't know. You just see a CT scan, heterogeneous opacity, and this is CT scan you see. You don't know what the pathology is.
I have recently done about 3 months back. I done a case like this. We made a diagnosis of adenocarcinoma because everything has got eroded, everything was there. And as you said, we saw the patient on table. Put an endoscope inside, it's only an AFRS. So open it up. AFRS is not going to breach dura or is not going to breach any one of these arteries and nerves. So if it is an AFRS, there is nothing big. If it is other pathology, without taking biopsy and knowing what type of pathology, going inside for treatment is not very advisable. And if you think it is you want to preserve optic nerve, then you have to shift the optic nerve before the tumor. Find the optic nerve outside and then place from there. Similarly, for take that internal carotid artery at the paraclival regions, and from there you be careful and don't injure the ICA.
So actually, so once you see a CT scan like that, it can be tumor, AFRS, and you must also remember that even an pseudoaneurysm can present like that. And sometimes this actually is not a pseudoaneurysm. Once you, if it is correct as pseudoaneurysm, you get a bleeding like that. So I see even ICA bleed is possible. So I think we should always go for a MRI and sometimes a contrast CT so that we can differentiate aneurysms or maybe tumors, and then we can go ahead. Because many times I operate with just with a CT scan, but that's not a. You may sometimes end up with a ICA bleed like that. So, what do you feel, Ramandeep sir? Am I correct in saying that you're
Please
muted, sir?
unmute yourself.
Yeah.
So my video on the ICA, is a similar, advice to fellow surgeons that when we did optic nerve decompression, we used to just go on the basis of CT scan. But a MRI would show if there is a pseudoaneurysm, it would show a flow void, which can be, picked up and help you diagnose it's a pseudoaneurysm. And the video I have, these are the points, we cover and how we manage that ICA bleed with the help of interventional radiology.
Okay, so maybe since we are running out of time, I think I can skip the frontal sinus and should go to the videos from all your sites, and then if time permits, I'll go for the talk. So maybe Dr. Hitesh, can you share your screen on the NLD injury, because NLD is a very basic thing. I don't want to speak on hi-fi stuff like ICA bleed and all those things because many youngsters are watching us. So common things first. So Dr. Hitesh, can you share a screen here?
Sir, please,
yeah,
you
I will
stop
stop
this.
share. Sorry, yeah, 1 minute, I'll stop share. Okay, yeah. Okay.
So it is visible.
Yeah, I'm seeing you.
This is a case of enterocoinal polyp. There was a wide maxillary ostium. And while I try to remove the uncinate from here with debrider, okay, I injured the nasolacrimal duct here.
No, so there, okay.
So now my question is, sir, how to manage this?
How to manage the injury? Professor Omura, are you there?
What to do, sir, in this case?
I got the question. Professor Omura?
Yes.
So, did you get his question? So he accidentally injured the NLD there. How do you manage this now?
This is how to say? So from the movie, what this is a orbit. You injured.
I think that's the orbit. Yeah, I think it's actually angled endoscopy or looking.
No, sir. No, sir. That was not orbit, sir. This is nasolacrimal duct.
I cannot. Yeah, from the
even actually,
I cannot understand.
Oh, okay. So this is where is NLD? Can you come again?
This was.
There. Okay.
Yeah.
So that's a very wide maxillary sinus opening, and here damage the NLD there superiorly there.
Yes, sir. That was not orbit.
Where is the? I cannot understand.
Here.
This is the maxillary sinus.
So this is the maxillary sinus opening. Wide maxillary.
This is the view of 70 degrees, sir.
70-degree endoscope. This is the maxillary sinus left side, and there is your injury there.
This is another nasolacrimal duct.
Yes.
Yeah, that's an nasolacrimal duct. Yes.
Right.
Yes.
So how do you manage it?
And you injured by
debrider,
or forceps?
Micro debrider, sir. Micro debrider.
I think how to say, you don't have to do that. This is a very small like a injury, and you don't have to do the DCR. I just even you leave it. Then
sir, what is the advice to patient?
No. So you just need you can leave it like that.
Post-operative the nasal drip.
Yeah, post-operative advice.
The eye drip and the massage. Then it's okay.
Ocular massage, okay.
Ocular massage, okay.
Yeah.
Then self syringing.
It's okay.
So no need to do a DCR.
No
need to do it. No need to do a DCR.
I think no need.
Okay.
And doing a DCR also is such an easy job there. You can just open the soft tissue and a bone around and leave it open. That's it.
Okay.
That is one way.
Okay. So you can also do a DCR. You can, I think probably as Umura said, he doesn't feel that it's necessary. What about other panelists?
Take the scissor, cut open this thing and just lay it open.
You can just widen it and lay it open like that. Okay.
Yeah, sir.
Is a stent required? Do you put a stent in this sort of patients?
No,
No, don't
Not
do this. Because if this fails, you can always do a DCR, easy job.
okay.
Like sir, in all medial maxillectomies, angiofibromas, we don't put a stent there.
Yeah.
It's open. It is
Okay.
left open. You make an oblique cut with a clean seizures, and it is always open. You don't need to
Okay.
do anything with that.
Processes. Okay, right. So it's a wide opening there. I can see a wide opening at the tears freely flowing. So probably nothing is required.
yes.
So can you go to the next video, Hitesh? Your next
Yes.
CSF leak video?
Yes, sir. Sir, in this video, while searching the sphenoid sinus, I had injured the posterior ethmoid, most posterior
base.
part, skull base of the most posterior part of the ethmoid roof.
There, okay. You can see the CSF leak there. Okay,
Yes.
okay.
Yes, sir. So my question is how to prevent such type of CSF leak while searching the sphenoid to all panelists.
Okay. Professor Omura, so how do you avoid a CSF leak once you're trying to open the sphenoid sinus? Here, actually, he was working through the ethmoids. He was trying to open the sphenoid, but then he accidentally poked into the skull base. This sometimes can happen in revision cases. So how do you avoid that?
Yeah, so from that, how to say, just basically, maybe how to say, this webinar, there are very beginners, ENT doctors also listen. So basically, if you open up something like open up sphenoid, open up maxillary, open up frontal, you have to show at least 2 anatomical landmarks. When you puncture something, you have to show 2 anatomical landmarks within the endoscopic view. Because if you don't show any anatomical landmark, then for example, even I see this endoscopic view, but sometimes I misunderstand where is where. So because in the endoscopic view, there's nothing, like there's no anatomical landmark. So I think it's better to show at least, for example, this endoscopic view, you cannot understand any anatomical landmark.
Okay, so you have to come out, get a panoramic view, get more oriented, and see what is before, what is after, and then you open the area, right?
Exactly.
Right.
And then you can understand how rotate the endoscopic view is. At least 2, not 1, 2. Then you can understand. You can fix the how rotate. That is a very, very basic thing.
Okay. Right. So any difference in opinion, Ramandeep sir? How do you avoid a CSF leak in such scenarios?
Injuries can happen. They will happen. It's very common for even experienced surgeons to become disoriented. And again, when opening a sphenoid, always have the nasal floor in view, have the choana in view, and don't poke blindly. I mean, that is the only advice we can give newcomers. So at least if you are, when we angulate the endoscope upwards, disorientation happens. And then we think that we are still looking head on, but actually we are looking superiorly. Your angulation changes. And the slope of the skull base, it's different for different patients. So that can also lead us into trouble. So I think with Hitesh, probably that's what happened, that there's the skull could be, the slope could be excess. There was disorientation. Instead of going head on, he kind of went upwards, and this happened. But it's managed very well. I mean, that's the way it has.
You can see that he managed it pretty well. I think Hitesh, I should be very grateful that you shared this, because people, they always shy away from sharing their complications. Everybody gets this sort of complications.
Everyone
You're a great surgeon. So thank you again for sharing
there
it.
is one more way, more ways preventing this injury. One to follow that imaginary line from the superior border of the maxillary sinus. Don't go above that ever.
You mean the orbital axis, right?
Yeah.
The orbital
and
axis,
the second thing is to see the superior turbinate.
Okay.
You have not to go beyond the half, above half. You don't go at the above half of superior
superior
turbinate.
turbinate. Okay.
Keep
Okay.
in close relation to the lower half, and you are
Okay.
there with the spread sinus. So I think that can prevent the injury.
Okay, good. So, any Anthony sir, do you got some video from your side? Is there something you want to share? Some complications, some difficult scenarios?
No, I don't have.
Okay, so what about Pavan?
No, I didn't.
So
I
what
have-
about
like, I could
Tushar?
not- that's all.
I think I know, I understand. So Ramandeep sir, I think you got some
Yes, on
something more,
ICA
right?
injury.
Yeah. Can you would like to share that?
Yes, please. So just tell me if you can, kind of see it. I'm going full screen.
Now I can see you. Yeah, we can see you. Yes, we're seeing you.
Okay, so this was a case of optic nerve decompression, traumatic optic nerve decompression. We looked at the CT. You can see the arrows pointing towards a fracture, which commonly happens. That's why we are decompressing. So we saw what we thought was hemosinus, which is again very common after facial trauma.
Yes.
And what we forgot to see that the patient was referred from outside. He had already gotten an MRI done. And we missed out on the MRI, the flow void. We didn't see the MRI because normally in our practice, we were not doing MRIs for optic nerve decompression. We were just doing CT scans and taking the patient up for surgery. So left side, optic nerve decompression, straightforward case. That's what we thought. We are remedializing the middle turbinate. So once that is done, I will just skip through these parts. That's the uncinate process. And initial part usually is done by our most senior resident. And again, you can see that, clotted blood coming out from the sinuses. And we are like, this is what is going to be in the sphenoid sinus also. So that's the basal lamella. We do an uncinectomy. This part, like I said, usually is done by the residents because these are the cases which don't have disease. It's easy to understand anatomy in these cases. So we did an uncinectomy. So I will just skip that. And then that's the bulla. We have removed the bulla. We reached the basal lamella. Then I showed them the superior turbinate. And then I was just telling them the various techniques that can be used for sinus surgery, for sphenoid sinus. We have the medial corridor or we have the lateral corridor. So once that is done, again, some hemosinus was encountered. Again, we suctioned it out. We didn't think too much about it. And that's what we discussed, that this is what we saw in the CT scan. Now, that's the last posterior ethmoid cell, a large cell, which can be seen. So this is the superior turbinate. We are sacrificing part of the superior turbinate because the sphenoid sinus has to be opened wide to address the lateral wall, because otherwise the instruments are going to clash with each other. Once that is done, I showed them the natural ostia, and I still remember the talks we were having in the operating room, that we can either open through the natural ostia or we can open through the ethmoid inferior-medially. As soon as I touched with the debrider, and boom. And the flow was horrendous, tachycardia, not of the patient, but operating surgeon and my assistant. See, even this suction can't keep up with it. So we went ahead. We are using now a 2-surgeon 4-hand technique. We used a much thicker suction to divert the flow away from the endoscope, because if your endoscope keeps on getting dirty, you are not going to end up seeing anything, right? So we just try to press that. We have not opened the sphenoid wide. So we thought that if we push in a pack, we are going to compress the bleed. But as soon as we try to push the pack, the pressure is so much that it pushes the pack out. But gradually, over a few minutes, we lost about 1 liter of blood in the process. We were able to pack it tightly. And this stopped the bleed. Patient was intubated. Interventional radiology was called. They said, shift the patient down. We have a radiology suite already ready and up and running. So the patient was wheeled into the interventional radiology. They did a CT angio. So see, the bleed has stopped. And this was the CT angio. You can see the
aneurysm, yeah.
Pseudoaneurysm, correct. So there were only 2 options. My interventional radiologist said, we'll try the coil first. If it fails, then the flow diverter, because the flow diverter is more expensive than the coils. But luckily, he's really good. I mean, he was able to coil this. And like I said, this is a team effort. ENT alone would not have been able to do anything. I also called in my neurosurgeon, just to be sure that what protocol or what else we can do. And that was the coil.
Right.
So this was 3 years ago. This is just when COVID had started. And look how the coil has occluded the segment. And this is a 3-year later CT angio. So this is the part where the coils were. It is basically almost normal with a slight, hinge, but the patient has not had any bleed or anything else. He is doing well. And I will also show you the post-operative cavity 3 years later. That's his post-operative cavity. So this is the case which really gave us sleepless nights.
It's an eye-opener case. This can happen to anyone, right?
This can happen to anyone. And I think we had just become so cocky that optic nerve decompression, I mean, you do it. So what? Let's just go in and we failed to see the kind of fracture of the lateral wall. It should have raised an alarm in us. So now as protocol, we have shifted to CT as well as MRI prior to optic nerve decompression.
Okay. I think we had two scenarios now. One is a pseudoaneurysm, which was mimicking an AFRS. So it's another case. So MRI for all carotid discections, a must.
Absolutely.
Right? So I think it's already time, and I can ask you probably to, I'm sorry that I couldn't touch the frontal sinus, and there is actually post-op. I just went halfway. We could just finish half. So maybe we have to wind up. So maybe I need some carry home message from each one of you for the younger generation people who are watching this. So let us start with probably Dr. Hitesh. Your carry home message, just
yes,
one or two words for the younger generation.
My message to all is, sir, please always do CT scan after giving antibiotic and steroid for minimum 10 days. Please go thoroughly through CT scan. Okay, then do the surgery.
Good. It's a nice message. So, Dr. Pawan, from your side?
I always tell to my residents, don't befool yourselves that you know each and everything. Read properly, read and develop skills to read the scans well.
Okay.
The theory part, read how to manage the things. Follow the basic principles of Fess level by level. Do a lot of cadaveric dissections, attend a lot of workshops, see to the YouTube videos, and then go step by step. Don't ever befool yourselves that you know everything and you can do any case. Don't just rush in doing it.
That's so true. So true, actually. Professor Omura, are you still there? Are you? I think it must be around 12 o'clock there. Professor Omura?
Yeah.
It's still there. Oh, so what is your carry home message for the younger generation? Your carry home message, like 1 or 2 points for the younger generation.
Yeah, just even the difficult scenario, even the very like a skull-based surgery, but the basic is very, very important. So you have to focusing on how to improve your basic skill, and even you are a beginner, but if you calculate your skills, then definitely 5 years later, 10 years later, you can be a skull-based surgeon. So,
okay,
thank you very much.
Thank you. And I think there are a couple of questions. Maybe I can just take 1 or 2 of that probably before I wind up from Anthony sir. And okay, so can you just broadly in like 1 or 2 minutes say how to approach the frontal sinus, because there are 2 questions about frontal sinus and other is about the maybe the frontal sinus, because we couldn't touch that during a talk. So Anthony sir, into like 5 minutes maybe maximum, how do you approach the frontal sinus?
Frontal sinus is best left alone when there is no disease. That you got to always keep in your mind. If there is a disease, you can do 2 ways. For the learning surgeons, it's always safer to do intact bulla technique. Okay. For learner surgeons, it's always safer to do a bulla down technique. Okay. So first you read the CT scan properly, see how much is the frontal recess and where is the frontal ostium and what are all the cells. So first thing is you do a good uncinectomy, remove the posterior wall of agonizing, try to find out the drainage pattern, whether it is a medial or lateral. As you know, commonest thing is the medial drainage. So go posterior and medial, find the ostium, try to take it out and check it up. You do it with an angled scope.
Angle scope. Okay. So
Angle-
angle scope, read the scans properly. Drainage pathway. Okay.
Drainage pathway, then take it out. And always, whenever there is I have a type 3 frontal cell, but we are having a cyclone here, a lot of powers in the display. I couldn't.
Okay. I understand. I know. Okay.
Type 3, if there is the frontal nasal is cleared, still frontal can be obstructed. So try to locate the frontal sinus, make it wider. And unless it is mandatory, don't do bigger surgeries like draft and other things, unless it is absolutely warranted.
Okay. So thank you, sir. You very well summarized that, and maybe one carry home message for the younger generation, something from your side.
Plan well your surgeries. So it's always safer to go to a senior in the planning stage, then giving a complication and then calling them. So plan properly from your CT scan. What are you going to do? What are your steps, and where are you going to stop it? So plan that properly, and then you are always keep updating. Learning is lifelong.
Okay, that's good. That's so nice. So nice. Actually, now Ramandeep sir, maybe you can have. There is one more question actually. The post-op management of sinusitis after surgery. Can you, like, in couple of minutes touch on that? The post-op management after surgery.
Okay.
Like you
So
use steroid
basically,
doses.
what we do is, number one, pre-op counseling is very important. You have to talk to the patient and tell him the importance of post-operative follow-up and post-operative medical management, which we are going to give. We also start nasal douches, even though his nose is full of polyps. The wash is not going to get anywhere, but we start nasal douches to get him into into the habit of what it is going to be like post-operatively. It is very important to kind of let them know the feel of a nasal douche. So they are already mentally prepared. Then they go ahead with the surgery. Post-surgery, normally we don't use any nasal packing, and we start nasal flushing about 24 to 48 hours after the surgery. First, it's just with plain saline, and they can just kind of flush out the clots. Once the clots are out, it actually is easier to suction and clean the nose a few times surgery. So I usually call them 1 week post-operatively, and they're already on nasal douches. And then we also tell them, this is also explained again pre-operatively, that there would be times during season change or when you are you have congestion and the polyps can kind of come back, but you would not require a surgery because your sinuses are already fully open. We would just give you maybe a cycle of oral steroids depending upon the kind of disease, and that would take care of the disease. Many times, once we give the oral steroids for patients who can't tolerate oral steroids and kind of initial shrinkage has taken place, we give budesonide respules diluted in water, and they can wash it with that. Again, washing is the most important. Why follow-up is important? Because when they come to us, we can peek in with an endoscope, and if there is minimal polyposis, intranasal steroids is going to take care of it. If it's slightly more, then maybe you can give budesonide douches. And if it's complete blockade, patient can't breathe, and post-operatively it looks like what it was pre-operatively, then a cycle of oral steroids is given. Now, dosages depends. There is no one particular dosage that it has to be started at 1 milligram per kg body weight. Many surgeons have their own protocols they follow. Some start with 40, 50, 60 milligrams and then slowly taper it down. Some give for 2 weeks, some give for 10 days, some give for 21 days. There is no defined guideline for that as yet. And I don't think so they will ever be, because it's very difficult. Every patient's response is different from the other one. For younger surgeons, take-home message is it's a steep learning curve. Don't straight away jump to fancy cases like we were showing here, a carotid injury and, start with good basic work. A good basic work is the building block of what you can do. Second, it also depends on your setup. You might be the most skillful surgeon there is around. If you don't have backup, you don't have ICU, you don't have a good interventionist, there's no point doing these cases, because you're going to land into trouble and then no one is going to come and save you. This is not to scare you, but to make you understand what needs to be in place before you embark upon the fancier surgeries. So good basic surgery, practice that. Go watch a few people. No one is perfect, number one. No one does the, no one technique works for everyone. So see a few people. Like I learned today that I used to just flush the fungal debris away. I learned Hitesh is using Merosil, using a nasal pack to kind of rotate it inside and push things out. So you learn things when you go around, and then make a protocol and follow that for yourself. It is not necessarily what works best in your hands is going to work best in my hands, or is going to work best in Dr. Amura's hand. Everyone has their own style of operating. There is no one correct way, but the algorithm needs to be correct. That is what we need to tell the young surgeons.
Very nice words, actually. Say golden words, actually. So in fact, I think I can summarize it now. So it was actually quite a big learning experience for me. I learned a lot from you all people, a lot of valid inputs. So thank you once again for all your time and coming over, and thank you once again, Professor Omura. It was a nice talk, and thank you all panelists. Thank you. I think we don't have further time to continue this panel, so just nice to meet you all and learn from you. Thank you, sir. Thank you.
Thank you.
Good night, guys. Bye-bye.
Good night. Good night.
Professor Vijaykrishnan sir are there? Gautam sir, do you want to? Can you conclude the session? Gautam sir is not there.
He's there.
Okay.
Sorry for responding a little late.
yeah.
Vijay actually is in Poland, so he must be having some connectivity problems. It was a very fruitful discussion. We all benefited. I also learned a lot from your discussions. Thank you so much for sharing your knowledge. Thank you very much, and have a good day. And of course, also our Japanese friend. So I was also very impressed, just like Velix, about his use of so little instruments to do his surgeries. I mean, it was so delicately performed with so little instruments. Thank you very much. Have a good day.
Thank you, sir. Good night. Good night.
Bye.
Thank
Bye.
you. Bye.